Well, thank you. Good afternoon. Thank you for joining me. It is a pleasure for me to introduce the California Surgeon General, our next plenary speaker, Dr. Nadine Burke Harris. Nadine Burke Harris, MD, is an award-winning physician, researcher, and advocate dedicated to changing the way our society responds to the public health crisis of childhood trauma. Dr. Burke Harris was appointed to California's first ever Surgeon General by Governor Gavin Newsom in January 2019. Prior to that, she founded the Center for Youth Wellness in 2011 and grew the organization to be a national leader in pediatric medicine and responding to children exposed to adverse childhood experiences and toxic stress. Her work has been cited in best-selling books and a feature film, as well as in NPR, CNN, Fox News, USA Today, and many others. Welcome. Thank you for being with us this afternoon.
Thank you so much. It's my pleasure to be with you, and I'm excited to be talking about wellness and what we can be doing. So I'll just dive into it.
Please do.
I think that for so many of us, this pandemic has been such a challenging time. And so the focus of my talk today is going to be just recognizing the ways that we as physicians can be sensitized to current stressors based on our life experiences, including adverse childhood experiences, and really understanding how our stress response works can give us guidance on how we can prevent and intervene with some of those consequences later on down the line. And then also talk about how addressing ACEs and providing trauma-informed approaches really is important for protecting all of our health from the impacts of chronic stress. Next slide, please. So one of the things that I talk about all the time is that physicians need PPE, right? Personal protective equipment against toxic stress. We've been battling a global pandemic of infectious disease, and we all recognized right away how important it was for us to protect those on the front lines from the virus itself, from the infectious particles. But one of the other things that is happening now as a result of the pandemic is that there are globally heightened levels of stress and adversity. And it's equally important for us to use the science to protect ourselves from the impact that this stress has on our physiology. And so we'll get into that as we go on. Next slide, please. So to start off with, we all know that being a physician is an incredibly challenging job, right? It's a high stress work environment. Our workloads are even increasing. We got to deal with EHRs, quality metrics, patient satisfaction surveys, cost metrics, challenges in the workplace, even in terms of our own personal safety, as well as keeping up with the latest and dealing with all of the challenges of efficiency and clerical burdens and all of that kind of stuff, right? And then throw on top of that, being on the front lines of responding to a global public health emergency. Next slide, please. But what we recognize is that how we respond to these stressors can be profoundly impacted by experiences and events that happened in our lives many years ago. And we know this from the research that comes from the CDC and Kaiser Permanente, the groundbreaking adverse childhood experiences study published now more than 20 years ago in 1997, in which they evaluated 10 categories of adverse childhood experiences. Those include physical, emotional, and sexual abuse, physical and emotional neglect, and growing up in a household where a parent was mentally ill, substance dependent, incarcerated, where there was parental separation or divorce, or intimate partner violence. And what we now understand, and really the two things that this groundbreaking study showed us was, number one, next slide, please, that adverse childhood experiences are incredibly common. So almost 2/3 of Americans have experienced at least one ACE, and almost 16% have experienced 4 or more. We see this occurring in every latitude and every longitude, every racial and ethnic group, every socioeconomic group, although certain groups are more impacted. But we really see that ACEs affect all of us. And when it comes to us as physicians and clinicians, we see that we are not spared, right? When we're talking about how many of us have experienced adverse childhood experiences, we recognize that that includes us as healthcare providers. But the other thing that the CDC and Kaiser showed us in their groundbreaking study is that adverse childhood experiences have a profound impact on not just the stuff that you would intuitively think of, risk of mental health conditions or risk of behavioral health conditions like substance dependence, but also increased risk of serious chronic diseases. Next slide, please. And what we now know is that ACEs dramatically increase the risk for 9 out of 10 of the leading causes of death in the US, including heart disease, cancer, accidents, chronic respiratory disease, stroke, even Alzheimer's. And so what we see here is a list of the 10 leading causes of death in the US pre-COVID, and the odds ratios that are associated with having an ACE score of 4 or more. Now, advances in the science over the past several decades points to why this happens. And fundamentally, at the root is our biological stress response. Next slide, please. So what we see is that when we have a stressor or a threat that activates the amygdala, which sounds the alarm and turns on our stress response pathways, our sympatho-adrenomedullary axis, the SAM axis, which results in the release of adrenaline from the adrenal medulla, or the HPA axis, the hypothalamic pituitary adrenal axis, which results in the release of cortisol, which is more of a long-term stress hormone from the adrenal cortex, right? And that activates our biological stress response. Next slide, please. And what we see as a result of that is that activation of the physiologic stress response is influenced. And this is a little bit of a complicated slide, but I will just say what it demonstrates, and this was a piece that was published in the British Medical Journal in 2020. What it demonstrates is that early adversity interacts with our genetic endowment, right? Genetic variations alter our susceptibility to adversity. And when the combination between the adversity that we experience and our genetic predisposition can lead to changes in our brain and neurodevelopment, lead to changes in our stress response and immune regulatory systems, right? And the way those changes are carried throughout adulthood is because these exposures in early in life can ultimately lead to epigenetic changes in the way our DNA is read and transcribed that ultimately affects the functioning of our biological systems throughout life. Next slide, please. So that is kind of a long way of saying, ultimately, we have early life adversity, and that can be buffered by the impact of protective factors, which is critically important, or that our predisposing biological vulnerability can also affect our risk, leading to changes in the neuroendocrine and immune systems that ultimately leads to long-term changes in our health. And these changes to our stress response system, our brains, our immune system, our hormonal system is what is now known as the toxic stress response, right? It's like what we, when we refer to toxic stress, this is kind of a common confusion. Oftentimes we'll see toxic stress referred to as the stressor, right? But what we know is that the definition of toxic stress is actually the biological stress response. Next slide, please. And it really refers to this prolonged activation of the biological stress response in absence of that adequate buffering caregiving systems. Next slide. And so the National Academies for Sciences, Engineering, and Medicine published a report in 2019 in which they clearly looked at the consensus of medical evidence and defined the toxic stress response as the prolonged activation of the stress response systems that can disrupt the development of brain architecture and other organ systems and increase the risk of stress-related disease and cognitive impairment well into the adult years. Next slide, please. Now, one of the things that it's really important to recognize is that the 10 categories that were identified in the adverse childhood experiences study are not the only categories of things that can increase risk for developing the toxic stress response. Other factors, such as experiencing poverty or exposure to discrimination or exposure to the atrocities of war, can also sensitize the stress response system and increase the risk for the development of the toxic stress response. Next slide, please. And as a result, what we see is these long-term changes to our biological systems, but really the health impacts can be difficulty with modulating or turning off our stress response system, or a heightened response to stress, or difficulty with executive functioning, planning, decision-making, impulse control, emotion regulation, increased risk of risky behaviors or addiction, increased risk of infection, autoimmune disorders, chronic inflammation, and on and on. So there's a long list. And part of the piece that's very important to understand is that the underlying biology, the underlying driver is this prolonged activation of our biological stress response as a result of exposure to high doses of cumulative adversity in childhood. Now, one of the things that it's also important to recognize, next slide, please, is that this biological stress response can be handed down from generation to generation, both behaviorally, right, as those who are exposed to high doses of adversity and who may be exhibiting symptoms of toxic stress are more likely when they go into parenthood to hand down those behaviors, but also physiologically, right? Because what we now understand is through some of these epigenetic pathways, there's increased risk for future generations. Next slide, please. What the research shows us about physicians and ACEs is in looking at one particular study in Northern California, we see that we as physicians are not spared from having experienced adverse childhood experiences. So one study found that almost half of physicians had experienced at least one ACE, with almost 10% experiencing 4 or more ACEs. And we recognize that that experience of ACEs increases our risk of, number one, being sensitized to subsequent stressors, right, through that toxic stress response, and then also leading to other adverse outcomes. Next slide, please. And what we see is that many of the associated health conditions that are associated with burnout. When we looked at a systematic review of prospective studies looking at the physical, psychological, and occupational consequences of burnout, right? One of the pieces that it's really important to recognize is that there's a strong co-occurrence of many of the conditions that are associated with the toxic stress response that occur in the setting of burnout. And so one of the questions that we are beginning to ask is whether or not that physiologic stress response, that prolonged activation of the biological stress response or the toxic stress response, plays a significant role in burnout. And one of the pieces that is key about understanding this connection, right, is that we know, as I said before, that those who have experienced high doses of adversity in childhood not only are at increased risk of developing these negative health consequences, but they're also at increased risk of developing, of even if you don't have these negative health consequences, being sensitized to subsequent stressors, right? So that means that you may go through most of your life and not have any consequences, health consequences, and then an additional cumulative stressor happens, and that is enough to tip you over into being symptomatic, right? And I think that is something that it is extraordinarily important for us to be cognizant of now that we're all going through a pandemic. We're cut off from our usual sources of buffering, caring relationships, our usual outlets that help to mitigate against the development of the toxic stress response. And for many are experiencing what feels like burnout. It feels like this chronic activation of the stress response, which may involve the toxic stress response. Next slide, please. So all of this, for me, when we hear about, when we understand the role that early adversity plays, what the toxic stress response is, right? And how it is connected to our increased vulnerability to subsequent stressors, we know that what is predictable is preventable and treatable. Next slide, please. What we know is that toxic stress is amenable to treatment, just like any other health condition. And we recognize that now that we understand the mechanism of toxic stress, we have new opportunities to more precisely interrupt that stress response, break the intergenerational cycle of ACEs and toxic stress, and promote a cycle of health and well-being. And what we know is that early intervention improves brain, immune, hormonal, and genetic regulatory control, and that treatment of toxic stress in adults is critical for prevention of transmission of the neuroendocrine, immune, and metabolic, as well as genetic regulatory disruptions to the next generation. Next slide, please. So in California, in response to this science and this new understanding of how early adversity puts us at greater risk for long-term health consequences, we created something called the ACEs Aware Initiative. Now, normally when we talk about burnout, when we talk about the toxic stress response, when we talk about the impact of physicians and all the things that we have to do, the stress of the job and how it wears us down, we talk about it in the context of what we can do on the individual level to promote our own well-being. And I'll talk a little bit about that. But one of the things that's really critically important is this recognition that systems matter. Our ability to recognize and respond to the stressors that are around us and the heightened level of stress and distress that we are encountering among our patients, among our family members, among our community members, right? That is actually a critical piece of addressing the stress that many clinicians are under right now. And so when we talk about responses to prevent burnout, stress, toxic stress for clinicians, I want to start by talking about systems and some of the systems that we've implemented here in California. So we started by creating training for our primary care clinicians on how to screen for ACEs and how to identify the signs and symptoms of toxic stress so that they can more effectively understand and intervene clinically. We also are reimbursing, right? Because anything that we want providers to do, if we value it, we should pay for it. So in California, we've started in our Medicaid program, and we are paying for ACE screening in children and adults and training our clinicians on how to respond with trauma-informed care. We're focusing on some of the buffering supports and understanding how to implement trauma-informed care. And we're building cross-sector networks of care to support children and adults so that it's not just on the clinician. We recognize if our environments shape our biology, that our response can't just be about what we do in the exam room. We recognize that we have to partner with others who can be of assistance in improving outcomes for those that we're caring for. Next slide, please. And we recognize that the issue has never been more urgent. Now more than ever, we need to be implementing trauma-informed care in everything that we do, because the multiple public health emergencies that we are experiencing right now between the COVID-19 pandemic, which is plenty, once in 100 years pandemic, the impact of climate change. In California, we're dealing with wildfires, and the sharper focus on the deeply rooted systemic racism in our society is really bringing a lot of these stressors to a head. And so we recognize that trauma-informed systems have never been more important. Next slide, please. Because it turns out that trauma-informed care isn't just good for patients, it's also good for physicians, because it establishes the physical and emotional safety of patients and staff. It builds trust between providers and patients. It helps us recognize the signs and symptoms of trauma exposure on physical and mental health, and promotes patient-centered and evidence-based care. It also ensures collaboration between provider and patient to achieve mutually agreed upon goals. And it focuses on providing care that's sensitive to the patient's racial, ethnic, and cultural background and gender identity. Next slide, please. So again, grounding in a systems-based public health approach to trauma-informed care, we recognize that an effective response to ACEs and toxic stress requires prevention at all levels, right? So we learn, we hear about primary, secondary, and tertiary prevention. Primary prevention is really focused on everyone, preventing something from happening to begin with. Secondary prevention is really about doing early identification, right? So it involves screening so that we can identify individuals who have experienced an exposure and try to prevent the development of the symptoms, disease, or other negative outcomes as a result of that exposure, as well as tertiary prevention, which is really treatment, right? It's targeting individuals who have developed a condition, a disease, or an outcome, and seeks to lessen the severity or the progression, right? Next slide, please. So when it comes to prevention of ACEs, in California, one of the things that we've done is implemented the broad scale ACE screening. And the purpose of ACE screening, number one, is to identify those patients who are at risk for development of the toxic stress response and ACE-associated health conditions, so that we can intervene to actually do prevention, right? That is, prevention should be what it's all about. And we know that universal routine screening. So it turns out we as physicians actually don't do a great job of knowing who might be experiencing ACEs and who's not. And so universal routine screening promotes health equity and improves quality of care. It enables that prevention and early detection as well as early intervention. And it improves the quality of our care for ACE-associated health conditions like chronic lung disease or asthma or heart disease by recognizing the toxic stress response as a treatable component of that health condition. So it's a little bit like, one of the things I often say is for someone who is treating a patient who has tuberculosis, if you know that that tuberculosis is in the setting of HIV, you approach your treatment differently, right? And it's the same thing with ACE-associated health conditions. If we recognize that that autoimmune disease, right, is happening in the setting of the toxic stress response, then we want to treat the autoimmune disease, but we also want to treat the toxic stress response. We have to do both, or we'll continue to have poor outcomes for our patients, right? And that's exactly what this is about. It's really about helping the primary care clinical teams identify additional health and social supports for patients and families to really treat that toxic stress response along with treating whatever ACE-associated health conditions that the patient may have. Next slide, please. So what we know is that primary care is absolutely a critical place for this response to be happening. And we can apply these principles of trauma-informed care. As I talked about, we can supplement usual care, right? So the standard of care right now for addressing the toxic stress response is applying the trauma-informed care, supplementing usual care for ACE-associated health conditions by providing patient education on toxic stress and also offering strategies to help regulate the stress response. Validating strengths and protective factors, that's incredibly important. And then when appropriate, not every patient is going to need a referral, but when appropriate, referrals to patient resources and interventions, such as educational materials or social work or care coordination or a community health worker. And then following up using that presenting ACE-associated health condition as an indicator of treatment progress. So for example, if a patient presents with severe asthma that's difficult to manage and they have 6 ACEs, as we are doing the treatment, it's really looking at how's that asthma management doing, how many exacerbations, how many hospitalizations, and with that effective treatment for the toxic stress response, do we see that coming down? Next slide, please. Some of these evidence-based strategies for regulating the toxic stress response are included in the Surgeon General's report for ACEs, on ACEs, toxic stress, and health. But they're included here. They include things like supportive relationships. We know that safe, stable, and nurturing relationships actually help to interrupt the stress response and decrease and are associated with decreases in the neuroendocrine, immune, and even genetic regulatory impacts of toxic stress. So they really help to regulate the stress response. Things like balanced nutrition or the supplementation of certain nutritional factors like polyunsaturated fatty acids that are associated with regulating certain aspects of the toxic stress response. Physical activity, really important. Practices like mindfulness. All of these factors that you see here are associated with reducing stress hormones, reducing inflammation, and enhancing neuroplasticity, which is really, that's the focus of treatment for the toxic stress response. Next slide, please. One of the other critically important pieces is ensuring that patients get access to the interventions that help to regulate the toxic stress response within communities, right? And so one of the things that we've done here in California is create what we call networks of care, which is an interdisciplinary group of health, education, human services, professionals, community members, and organizations that are all part of supporting children, adults, and families by providing access to these evidence-based buffering resources. Because when we look at these evidence-based interventions, again, some of them we can prescribe in clinic and monitor, but some of them are really going to be found in the community. In addition, we recognize that these networks of care can help to prevent the development of the toxic stress response, even if someone is exposed to ACEs or other risk factors for toxic stress, and as well as intervening. So the role of these community networks is to prevent, treat, and heal. Next slide, please. As we look into the future, California has really sought to take this evidence, take the science and evidence of ACEs and toxic stress and put them into practice. So we have really made some major investments in investing in, for example, children's behavioral health. We know that we are in that the pandemic has really posed a once in a generation level of stress and disconnection on the children and youth growing up in this generation. And that's a big part of the reason why we recognize that we need to increase access to some of our children and youth behavioral health services. And so our governor just signed a $4.4 billion investment in children and youth behavioral health statewide, right? We recognize that mental and behavioral health interventions are one of the evidence-based interventions that are necessary to combat the toxic stress response and improve healing. Public education, absolutely critical. Trauma-informed care across sectors, supporting community health workers to be part of connecting individuals and families to resources, as well as additional research to advance our understanding of the toxic stress response and how we can address it. And of course, investments in our health information technologies and infrastructure. Next slide, please. One of the pieces that's really key is this recognition that as we in the healthcare field feel sometimes overwhelmed, overburdened, stressed, right? That no sector can do it alone. In order to be able to address these issues, we need to be in partnership and we need coordinated action across the board with public health, social services, education, early childhood, justice, you name it, our employment, our workforce, our employers, right? All across the board, we really need this cross-sector response because none of us can do it alone. Next slide, please. It's so critical that we as healthcare providers apply this science to help ourselves as we have helped so many. We recognize that physicians are not immune to the effects of toxic stress or to the additional burdens that all of the current stressors are placing on us. And so in order to do that, there's a couple of resources that I want to offer. Number one, next slide, please. Our roadmap for resilience, the California Surgeon General's report on adverse childhood experiences, toxic stress, and health. The section on healthcare really does a deep dive into the latest evidence and information about the toxic stress response and what interventions really can make a difference and how we can better improve not only the quality of the care that we provide to our patients, but also the systems and practices that we engage with on a day-to-day basis to provide trauma-informed care that improves the well-being of the clinician as well as the patient. We also have a free 2-hour online training at acesaware.org that anyone across the nation can take and receive CME and MOC credits. And we also have cross-sector briefs to identify preventive strategies in different specific sectors, such as the social service sector or the public health sector. Next slide, please. We also have evidence-based tools and strategies. These are available at acesaware.org, as well as for anyone who has experienced ACEs and would like to get information, lay information, or to share information with patients. Numberstory.org is a national public education campaign that is focused on helping people understand what are ACEs, what are toxic stress, what is toxic stress in simple lay language, and offers resources for what people can do on a day-to-day basis, evidence-based interventions in terms of mindful breathing and other strategies, as well as if someone is in crisis, links to crisis resources. Next slide, please. And I want to encourage folks to either join or build a network of care in your community. And there are, we actually have a roadmap on how to do that at acesaware.org/network of care that has information on who should be in the network of care. How does the network of care communicate? What are some of the kind of the IT infrastructure that's necessary on the back end, and how to do all of this so that we can better support our patients and ourselves with trauma-informed systems of care. Next slide, please. We know that the adverse childhood experiences and toxic stress represent a public health crisis. And we also know that the COVID-19 public health emergency has only exacerbated the stress, adversity, and for some, frank trauma that we are all experiencing. But when we take this systemic approach, when we take a public health approach, one of the things that I say often when I came into the role of California Surgeon General is we set a goal of cutting ACEs and toxic stress in half in a generation. And when we look at other examples of public health approaches and what they've been able to accomplish, we see that when it came to smoking, we went from 25% of 12th graders who were smoking in 1996 to one generation later, right? In 2016, the number was 3.6%. That happened in one generation. When we look at, for example, childhood lead poisoning, next slide, please. We see that over the course of 20 years, we dramatically cut the prevalence of childhood lead poisoning through secondary prevention measures in terms of routine screening and responding with public health interventions. And when we look at how treatment and and tertiary interventions can impact outcomes. We look at the example of HIV, right? Next slide, please. We see that between 1995 and 1997, the dramatic drop in death rate from HIV with the introduction of highly active antiretroviral therapy. So when we look at examples of primary prevention, as in with smoking, where we were preventing folks from starting smoking to begin with, right? Profound progress over 2 decades. When we look at the impact of secondary prevention, as with lead poisoning, where we implemented a screening program that helped to drive down the prevalence of childhood lead poisoning. And when we look at a tertiary intervention, such as highly active antiretroviral therapy for HIV, and we saw a dramatic drop in the death rate. What we see is that when we combine all of these, we can achieve in 1 generation substantially cutting, and I believe that we can get to cutting in half our rates of adverse childhood experiences and toxic stress. But it really begins with us. It begins with us as healthcare providers using this science to put our own oxygen mask on, to implement some of those evidence-based strategies for buffering the toxic stress response so that we can continue to be on the front lines to care for our patients. Next slide, please. Thank you so much. And it's been a pleasure to share these comments with you.
Thank you, Dr. Burke Harris. We really appreciate all the great work you're doing in the state of California, and we're grateful for you to spend your time with us here this afternoon. Thank you again.